Okay, we want to start a review of Unit 2 for Adult Health, and this test will be on Thursday of this week, and it's going to cover burns, sensory, and immunity with the HIV part in there. And I'm just going to give you just some highlights. I can't review everything because it's so much, but I can give you some extra PowerPoints, pictures to look at, and some additional review information. The first thing I'll start with is a review of the eye medications. Specifically, you want to remember the difference between a miotic eye drop and a mydriatic eye drop. And one of the key things here is to focus on what happens to the pupil. With a miotic eye drop, you're going to constrict the pupil. With a mydriatic eye drop, you're going to dilate the pupil. And so we talked about different times when one or the other of these is more appropriate. For example, the miotic eye drops are more appropriate here at the top for glaucoma as a routine daily treatment. They come in a drop form applied intraocular to the eye. And what happens basically is that when we give the miotic eye drop and we constrict the pupil down, that helps to open that trabecular meshwork to drain off that aqueous humor better. So it actually decreases the pressure in the eye by draining that fluid. Mydriatic eye drops are used more often to dilate the eyes for an eye exam or for an eye surgery when we need to get to the back of the eye, like maybe to the lens or to the retina to do our surgery. We'll give mydriatic drops the morning of the surgery or immediately prior to the surgery to open up the pupil so that the doctor can get into the back of the eye for the work that needs to be done. These could be used for a glaucoma patient if, and this is a big if the patient's coming in to have eye surgery, like on that trabecular meshwork, we talked about the trabeculectomy, or a surgery like that on glaucoma would be the one-time pre-op that you would give these mydriatic eye drops. But as a daily therapy, routine management of glaucoma, it's going to be the miotic drops that are given to actually open the trabecular meshwork to help drain that fluid. Also, there's one surgery that we did talk about where we wouldn't give the mydriatic eye drops as a pre-op because we don't want to open the eye, and hopefully you remember that that goes with the corneal transplant. Since the doctor would just be working on that outer dome-shaped clear covering over the eye, we would not want to get to the back of the eye, therefore we would not need a mydriatic eye drop. One of the examples we talked about where you would need a mydriatic eye drop to get to the back of the eye is with cataract surgery. We talked about how the lens is removed and replaced with a new artificial lens. That would definitely be one of the times when a mydriatic drop would be used. This next slide just, well, to me it's funny, but also it helps you to review Timolol or Timoptic, which is an eye drop that we use very frequently for glaucoma, and I want you to remember that it ends in olol, so that makes it a beta blocker. And you should know that beta blockers are also prescribed for hypertension and to lower heart rate. But since we're giving this one as an eye drop, we would not want cardiac effects. And we talked there about after you apply the drops to the patient's eyes that you're going to want to stand and hold pressure at the inner canthus of the eye for at least 1 minute to prevent systemic absorption. That's really important because if it is absorbed systemically, you could get systemic side effects, related to dropping the blood pressure and dropping the heart rate. So a couple of things. Right over here, look at what this policeman says. This is important. He says we can't stop the eye's increasing humor, but we can interfere with aqueous humor production, which will reduce the pressure. In other words, this drug stops more from being produced. It doesn't help it to drain better. So you want to, you want to remember which drugs have which purpose. Some of the drugs for glaucoma help the system to drain better. Timolol is one of those that actually helps it to stop being produced. You won't produce as much when you take Timolol. So you want to know which ones have which effect. And then also pay attention to these side effects over here. Rash, dizziness, blurred vision, dry eyes. Those are some of the side effects. And most of those things are really more localized reaction like the blurry and the dry eyes. The side effects that I want you to be more cautious of are the systemic side effects that are related to that drug having effects on the cardiac system. And again, here's a review of cataracts, and it just talks about some of the symptoms. It is like looking through a fog. We said that everything is very hazy. It's like swimming in a pool underwater with chlorine and then coming up and looking around. Everything really looks cloudy. So a cloudy, opaque lens. One of the things that I specifically stressed about cataracts is that it's not painful. It's just a clouding over of the lens. It does occur gradually, and it impairs both near vision, distance vision, peripheral, central. It affects all types of vision. Whereas remember with glaucoma, they're starting to slowly lose their peripheral vision, so they're developing tunnel vision. Cataracts, everything is cloudy or fogged over. Low acuity, this means with low acuity, it's not sudden, it's a gradual onset, and it's not severe or life-threatening in any way. There's not going to be a great increase in intraocular pressure. There's nothing that's going to cause permanent damage to the eye or to the nerve that serves the eye. This is just a clouding over of the lens. Usually this occurs with age, and you can speed up the process of clouding over your lens if you go out in the sun a lot without sunglasses on, and you get a lot of damage from sunlight to that lens. The treatment, surgery. There's no medication that's going to help cataracts. The treatment's going to involve giving those mydriatic eye drops to open up the pupil, go into the back of the eye, getting out the lens that's clouded over, and replacing it with a lens implant. And we talked about how that is an intracapsular extraction, and that back some time ago, years ago, that we did not replace the lens with the lens implant. We just removed the lens, and then people had the need for those cataract glasses, and we talked about how they had problems with depth perception, especially problems going up and down stairs because they couldn't judge distances very well. We're kind of changing subjects here for a second. Any picture I could find that was related, I tried to put here and have it as a review for you. We talked in class about HIV and AIDS and the difference between the two things. Remember that HIV is human immunodeficiency virus, therefore it's a human infection. It's not going to be transmissible from or to any animal. It's a human virus. And we said it will eventually, and we don't know how many years it takes for different people. It varies. An average is 10 to 15 years, but it can be longer depending on the health status of the patient, depending on their access to medications, their access to insurance, those kind of things. But some of the things here to keep in mind for a patient who you know you're working with that has AIDS, and we want to prevent transmission in the healthcare setting to our healthcare workers, but also maybe to other patients. The key thing is right here: maintain standard precautions. Standard precautions, remember, involves wearing gloves with any potential contact with blood or body fluids, and that should be with all patients all the time. And you want to consider all body fluids to be contaminated. So you don't want to think because you are giving your patient their medications for the day and maybe they have trouble, have trouble swallowing a pill, so they take it out of their mouth and then you touch it and put it back in their mouth or something like that. We want to consider all body fluids to be contaminated, and that would include things like tears, saliva, any kind of fluid that's coming out of their nose. Any fluid on their body is considered contaminated, even though we know that the fluids that it has been identified in, the virus, would be blood and things like sexual fluids and breast milk. That's the ones that we talked about. But we want to consider that all people have contaminated body fluids. Sorry, hang on. I'm sorry about that. I'm going to see if I can go back a slide and finish that. Okay, a couple of things that I want you to keep in mind. Remember, standard precautions apply to all patients. We talked in class a lot about the window period, so you never really know who is infected. Just because they haven't tested positive yet doesn't mean that they won't. So you want to consider everybody contaminated with HIV. Just consider that everybody's HIV positive. So you want to have standard precautions with all people. Of course, use your protective barriers where they're appropriate. You don't need to use a face mask for somebody who's, of course, not coughing or not. It's not going to have any way that you inhale that. Those would be used. Mask. Think of occasion when you might be, or a healthcare worker might lean over a patient. The person I think of here that really needs their mask and probably even their eye shield would be like a dental hygienist or a dentist who's leaning over a patient's mouth while they're cleaning teeth or working on teeth, and they could get splattered with blood in their eyes or into their mouth. Those people really have to have their mask and their eye shield. We never recap needles and syringes. Y'all know that. Clean up the spills, blood and body fluid. 1 to 10 concentration of bleach is effective. So in other words, 1 part bleach to 10 parts water. But keep in mind also that HIV is not a very strong virus. When it's outside of the body, we call it an obligate virus, which means it has to have a human host. It doesn't survive for very long outside the human body at all. The virus that we talked about that's much stronger and has the ability to last longer outside of the body is Hep B, hepatitis B. Some clinical manifestations of AIDS. We talked about the definition of when it's actually called AIDS, and that's when their helper T cell count, which is the CD4 count, drops below 500. They have to be HIV positive, and they have to have an opportunistic infection. Well, one of the reasons I wanted to put this up here is because this actually lists some of those opportunistic infections. So it would be things like that PCP pneumonia that we talked about, pneumocystis carinii pneumonia, toxoplasmosis, which is a type of encephalitis. It's an infection that attacks the brain. Just all of these. Candidiasis is yeast, but this is like when they have yeast in their esophagus, in their mouth, really bad thrush for no reason, a really bad vaginal yeast infection that's not responsive to treatment, and it's just, you can't get it to go away. TB, cytomegalovirus, shingles, just a wide variety of things. Kaposi sarcoma is actually a type of cancer that only people who are immune suppressed even get. So look at all these things and look at the fact that your patient has to be immune suppressed to be at risk for these. Opportunistic infections, and the definition varies. Some say a CD4 count less than 200 is what defines AIDS, but we're using the CD4 less than 500. So just realize that different books can use different numbers there, but we're talking a severe suppression of their helper T count. And this is pretty simple, but just to remind you of the ways that you cannot catch AIDS, and we did talk about this, and first of all, you don't catch AIDS, you catch HIV, the virus, but you can't get it from a toilet seat. No case is ever traced back to handshaking, dirty dishes, sharing a bath towel, swimming. No cases like that. You have to share blood, or you have to share sexual fluids, breast milk, things like that. Now, even though these look like common household things, one of the ones I want to kind of point out to you, one of the things that you would not want people to share would be something like a razor. Anything that could potentially go from person to person in a quick way and transmit one person's blood to another person. We wouldn't want to share any kind of tattoo needles, none of that blood brother stuff like we talked about in class today. And then also with immunity, we talked about situations where your immune system is hyper-responsive. We call these hypersensitivity reactions. Anaphylaxis would be the most severe form of an allergic reaction or a hypersensitivity reaction. And we said that really anaphylaxis occurs based on the routes of injection or ingestion. So in other words, it's usually something that they ate, swallowed, or were injected with, like iodine. I like the picture because it has the bee sting, it has the pill that they're allergic to, it shows the shellfish, iodine like from an IV contrast test. All of those have to do with something that they either swallowed or were injected with. So peanuts, eggs, shellfish, bee, wasp, ants, and of the insects here, the bees are going to be by far the most common. Medications that have a reputation for causing anaphylaxis, penicillin's probably the biggest. Aspirin, we said, could be a problem for those asthmatic folks. And with anaphylaxis, you know it onsets rapidly. Their throat gets tight. We talked about bronchospasm. You would hear them wheezing. Laryngeal edema, that throat's closing up. Pay attention to the fact that they're losing their ability to talk to you. They're drooling because they can't swallow. Their mouth and their throat are swollen. If we, at that time, did take vital signs, you would see signs of shock, the low blood pressure, tachycardia, loss of consciousness. And remember, key thing, they should get epinephrine immediately. Epinephrine is the drug of choice to reverse anaphylactic shock. In people who are known to have anaphylaxis, so let's say they know that they have a severe bee allergy and they're going to go into anaphylactic shock, they should have an EpiPen with them at all times that they can access, or that whoever's with them can access. This, I don't want you to focus on all the fine points of lupus because that was last semester in 105. The only reason I've included this here is to remind you about autoimmune disorders where the body's attacking self, and we named a few of those specifically. Lupus was one of those, systemic lupus erythematosus. We also talked about multiple sclerosis, rheumatoid arthritis, scleroderma. Those are really the big ones, and we see young minority females having the highest number of cases, and it's the body's attack on self. Your immune system is not able to recognize self versus non-self, so it's attacking everything. So just review that, and that is a form of hypersensitivity. The immune system is over-responding. And then we're back to a few things related to the eyes. Glaucoma, remember, has to do with increased intraocular pressure. 10 to 21 is kind of considered normal, so when you are approaching the upper 20s, 30s, that pressure is getting pretty high. We talked about two different kinds of glaucoma, and this slide is particularly talking about primary or open-angle glaucoma, also called wide-angle glaucoma. It's the chronic form. It is this, we called it the sneak thief of sight, because the person doesn't really have symptoms that they notice for a long time. If they have symptoms, they'll talk about tunnel vision, losing the ability to change lanes when they drive on the interstate because they can't tell if there's a car beside them. It's not painful, and that is really key to remember, that at least initially it's not painful. It only becomes painful in the late stages if they're not compliant with their medicine and the pressure builds up to a high level. The pressure has to get really high before this person would have any pain. What you want to remember about glaucoma is that the person can actually stop the disease where it is. You can't cure it. You can't get that vision loss back. You can't, whatever's lost is lost. But you can stop the progression of the loss of the peripheral vision by being compliant with the medicines, and we did talk about that. One of the other disorders we talked about was sensory. We talked a lot about the ears. And otitis media was a big one that we talked about quite a bit. Otitis media meaning infection of the middle ear. That involves the tympanic membrane. And usually the picture's of a child, and usually it is a child, but adults can get this also. If it's a child, though, they're going to be pulling at those ears. They're not going to want to eat because sucking, especially on a bottle or breastfeeding, that's going to aggravate the pain. If the tympanic membrane actually does rupture and all that fluid comes pouring out, the pain's actually temporarily going to get better because the pain was due to that pressure behind the eardrum. Myringotomy tubes, we talked about tubes for this. They're placed through the eardrum, and it doesn't mean that you can't get an infection after that. It's just that you're going to know it quicker because all that infected fluid's going to start to pour out those tubes, and you're going to see it. We talked about Aralgan drops. Those are just going to numb the pain. It's not going to cure the infection. This person needs antibiotics. Couple of things again here with the eyes that we talked about in class. Refractive errors. This just has to do with being either nearsighted, farsighted, or having an astigmatism. And remember the difference. Myopia means I can see close up but not far away. So I can read my textbook but I can't read the chalkboard. That kind of thing. Hyperopia means I can see far away but not close up. So I can see the chalkboard then, but not my test, or I can't read my textbook. And the one that's associated with aging is specifically called presbyopia when it happens with age, and that's the people who need the little reading glasses. Astigmatism down here at the bottom is where they're blurry all over. It's due to an uneven curvature of the cornea of the eye. It has to do with that dome-shaped covering over the eye being lumpy and bumpy, and we said these people have a hard time wearing contact lenses. They tend to fall out. They make special contact lenses for astigmatism, but then you have a problem where they seal onto the eye so tightly that the eye can't breathe and they have problems. So astigmatism is usually best treated with just wearing eyeglasses. Glaucoma we've talked about, but maybe this will help you to remember it even more. The 3 P's of blindness: it is preventable, it's painless, but it's permanent. So it is the sneak thief of sight because they don't feel pain, so most people don't come in. Hopefully they'll pick up on the fact that they're losing their peripheral vision, they're developing tunnel vision, and come in. But at whatever point they come in, we can't get what they've lost back. Just keep that in mind. And then also in this unit, we did talk about burns, and we talked about stages of burns, 1st degree, 2nd degree, 3rd, and we even talked about 4th degree burns. They also had other names, so make sure you look at the other names for those. We talked about a superficial partial thickness, a deep partial thickness. That was the ones that I think were more confusing between the 1st and 2nd. 2nd degree, notice it has blisters. The deep partial thickness burn is a 2nd degree burn, and it will blister up. Once you get into full thickness burns, you're going to find that the patient, usually with 3rd or 4th degree, does not have pain because they have damaged the nerves. And if the nerves are damaged or burnt, they won't experience pain. And review with burns, a couple of points I just want to remind you of because it's been a while. Rule of 9s, be able to add up those burns. If I tell you somebody's legs, their arms, their genital area are burned, be able to give me those percentages. So go back and look at that for the adult. Also, with burns, we talked a lot about the assessment and 3rd spacing, fluid remobilization, when that fluid shifts out, when it shifts back in. And the respiratory assessment was key. So if somebody has those singed nasal hairs, remember that they've inhaled smoke, and that's the person that's at risk to lose their airway. So always keep that as your highest priority. And again, this is just showing you the different layers of the skin and the burn according to the layer. 1st degree, or that superficial partial thickness burn, a lot of times that's like a sunburn or a burn on the curling iron, that kind of thing. 2nd degree can be the same cause of the burn, but it's going to blister up. And then 3rd and 4th, usually that's a thermal burn that involved like a house fire, or they were actually in a fire to get that deep of a burn. I hope that this short review has been helpful. Please let me know if it is. We're going to continue to do some of this as long as people are viewing it. So please just, I hope this is helpful, and let me know if you find that it is.